My name is Dr. Paula Braverman, and I'm an adolescent medicine physician at Cincinnati Children's Hospital Medical Center. And today, this webinar is going to cover the safety and efficacy of the HPV vaccine. Just to start, I have no financial relationships report related to this presentation. There are more than 120 types of human papillomavirus, commonly referred to as HPV, with approximately 40 types that infect mucosal epithelium, while other types, for example, might cause plantar warts or warts commonly found on the hands and fingers. Among the 40 types that infect the mucosal epithelium, there are high and low risk types. The high risk types are associated with cancer, and HPV is an established cause of cervical cancer and associated with other anogenital cancers such as vagina, vulva, penis, and anus, as well as oropharyngeal cancers, particularly the base of the tongue and tonsils. With respect to cervical cancer, HPV is a necessary causative agent. Although most people exposed to HPV are asymptomatic and clear the virus, persistence of one of the 13 oncogenic types can progress to a precancer or cancer. The low-risk types are non-oncogenic but can cause lesions that are difficult to treat. Genital warts, known as condyloma acuminata, are caused by the low-risk HPV type 6 and 11. These low-risk types are also associated with recurrent respiratory papillomatosis, in which lesions on the vocal cords and surrounding tissues can affect voice quality and even cause difficulty breathing. Based on polymerase chain reaction genotyping studies, 79% of HPV-associated cancers are attributable to HPV. This distinction between associated and attributable is important because HPV-associated cancers, which are defined by anatomic location and cell type, may not be caused by HPV. Of the cancers attributed to HPV, approximately 92% are related to the HPV types found in the currently available 9-valent vaccine. More than 90% of anogenital warts are caused by HPV 6 and 11, which are also in the 9-valent vaccine. HPV is the most common sexually transmitted infection in the United States among both males and females, with 14 million new infections a year and an estimated 79 million people infected at any one time. The highest prevalence is seen in sexually active adolescents and young adults in their 20s, which is the same for other sexually transmitted infections such as chlamydia and gonorrhea. Individuals in this age group are at higher risk because of some biologic reasons, such as the presence of the exposed squamous-columnar junction on the cervix of adolescent females, which is a normal developmental finding, and also because of behavioral reasons, such as having more sequential partners and less consistent use of condoms. HPV infection has been documented very soon after the onset of sexual activity and has been found in 40% of college women within 24 months of their first sexual intercourse. This slide demonstrates that 1/2 of all new HPV infections in the U.S. occur in 15 to 24-year-olds. And as previously mentioned, high rates in this age group are also seen, with 70% of gonorrhea and 63% of chlamydia in this same age group. As noted in the 2016 MMWR cited on this slide, on average, 30,700 new cancers are attributed to HPV on an annual basis, including virtually all cervical cancers at 99%, 90% of anal cancers, 71% of vulvar, vaginal, and penile cancers, and 72% of oropharyngeal cancers. Of the cancers attributed to HPV, 80% are attributed to HPV 16 and 18, and 12% are attributable to HPV 31, 33, 45, 52, and 58, which are the 7 high-risk types in the currently available 9-valent vaccine. HPV vaccination is the best way to prevent many types of cancer. But what is actually happening? As of the 2015 National Immunization Survey for Teens, we need to do a lot better. When looking at girls aged 13 to 17, only 6 out of 10 have started the vaccine series. This doesn't even address finishing the dosing schedule to provide the best protection, which is an even lower number. As you can see in Ohio, we are within the national average of 61% of girls starting the series, but lower than many states, including ones that have immunization rates of 70% or greater. Also, only 38% of girls in Ohio have completed the 3-dose series. Similarly for boys aged 13 to 17, only 5 out of 10 have started the series in the country, with Ohio being at 44%, and only 20.1% of boys have completed the 3-dose series in our state. Although there have been 3 HPV vaccines, including the bivalent and quadrivalent vaccines, as of January 1st, 2017, only the 9-valent is available in the United States. It is recommended for all females and males at age 11 and 12 and covers the majority of the types related to cervical cancer and genital warts, as well as the types most associated with other genital and oropharyngeal cancers attributed to HPV. This recommendation to start at age 11-12 is because the HPV vaccine is a preventive vaccine and only protects from the virus prior to exposure. The vast majority of children aged 11 to 12 have not been sexually active, and as we will discuss, the immunologic response to the vaccine is much higher in the younger age group. If the individual has already been exposed to a particular viral type, the vaccine will not be effective from disease caused by that HPV type. However, even if the individual has been sexually active, it is still recommended for them to get the vaccine because it is extremely unlikely that they have been exposed to all of the 9 types, and they will get protection from the types they have not yet been exposed to. HPV vaccine is also recommended as catch-up for females aged 13 to 26, males aged 13 to 21, as well as males who have sex with males and those who are immunocompromised through the age of 26. Use of the vaccine is permitted for all males through the age of 26, and both males and females down to the age of 9. Individuals who need to complete the HPV vaccination series and have started the bivalent or quadrivalent vaccine can finish the 9-valent vaccine. However, there is no recommendation to give the 9-valent vaccine to people who have finished the series with the older HPV vaccines, or to give 3 doses of the 9-valent vaccine to someone who is finishing off the series with that particular formulation. The 9-valent vaccine has 5 additional types that mainly are beneficial for females because it adds coverage for 15% of the causes of cervical cancer, which were not in the quadrivalent vaccine, which only covered 2/3 of the HPV-related cervical cancers. So, how effective is the HPV vaccine? The 9-valent vaccine contains the types listed on this slide. Seroconversion studies were conducted in males and females aged 9 to 26, and in the clinical trials, 99% of subjects in this age group seroconverted to all 9 HPV types. There is not a clinical assay available to measure titers, but the studies were used in a research protocol that measures geometric mean antibody titers known as GMTs, and found that they were higher for those aged 9 to 15 than those aged 16 to 26 in both males and females. Also, the GMTs for the 9-valent vaccine were not inferior to the results for the 4 types in the quadrivalent vaccine. It's important to note that the lowest therapeutic titer is unknown because you need breakthrough disease, and this has not happened to date when following subjects for many years who have received the quadrivalent vaccine. I wanted to find some terminology now ahead of the following slides. CIN refers to cervical intraepithelial neoplasia. VIN, vulvar intraepithelial neoplasia. VAIN is vaginal intraepithelial neoplasia. PIN, penile intraepithelial neoplasia. AIS, adenocarcinoma in situ. And AIN, anal intraepithelial neoplasia. There are 3 grades that are referred to in the literature and studies, which become progressively more severe as 1, 2, and 3. So for example, CIN3 is a designation that would occur before cancer, whereas CAN1 is early changes that are seen related to the particular cellular changes. There are 3 grades which become progressively more severe, numbered 1, 2, and 3. So, for example, CIN3 is a designation right before cancer, and CIN1 represents earlier, less severe changes. This slide shows you the results from the quadrivalent HPV vaccine studies related to the efficacy of the vaccine in preventing disease in 16 to 26-year-olds who did not have evidence of exposure to HPV as measured by having negative PCR testing and negative serologic titers. As you can see, the vaccine is very effective at 98% against high grades of CIN and AIS related to HPV 16 and 18. It is 100% effective against high-grade vulvar and vaginal intraepithelial neoplasia, 99% effective against genital warts in females related to HPV 6 and 11, and 89% effective against genital warts in males. It was 100% effective in preventing penile intraepithelial neoplasia of all grades, and overall 75% effective in preventing anal intraepithelial neoplasia grades 2 and 3 in males. Since HPV-related anal disease in females is similar to males, and females mount a similar serologic response to males to the vaccine, it was assumed by bridging that the vaccine would be just as effective in females at preventing anal cancer as in males, even though specific studies on anal disease were not done in females. It is important to note that the studies did not look for cancer as an endpoint, since it takes many years for this to happen, and the focus was on the precursors to actual cancer. This graphic summarizes the information on the new 2-dose schedule. If the patient is healthy and does not have asplenia, sickle cell disease, chronic granulomatous disease, or an immunocompromising condition, they are eligible for 2 doses 6 to 12 months apart, as long as the first dose is given before the 15th birthday. 3 doses are still needed for those with a medical condition that would be a contraindication to 2 doses and would include 3 doses, with the second dose being 1 to 2 months after the first dose and the third dose being 4 months after the second. However, there must be a minimum of 24 weeks between doses 1 and 3. This means that the first and third dose must be at least 6 months apart. So even if the second dose was given earlier, you still must wait the entire 6 months between doses 1 and 3. Recently, an article was published that did a systematic review of the literature and looked at the international experience in the real world with HPV vaccine. As you can see, the studies were from North America, Europe, and Australia, as well as New Zealand, and range from countries with high HPV completion rates like Australia to those with lower rates like the United States. Overall, 4 years after the vaccine was available in these countries, and even in countries with low coverage rates, there were consistent decreases seen for adolescents and young adult females related to cervical and vaginal infections with the HPV types in the quadrivalent vaccine, and in the clinical disease with genital warts, low and high-grade cytologic abnormalities on pap smears, and CIN2, 3, and AIS. Vaccination with HPV vaccine can dramatically decrease the prevalence of HPV in a short period of time. When comparing vaccinated women to unvaccinated women in different age groups within 6 years of the vaccine becoming available in that country, there was a 76% decrease in HPV prevalence in 18 to 24-year-olds in Australia, which had very high uptake of the vaccine, and an 89% decline in the U.S. among 14 to 24-year-old adolescents. The U.S. data was based on self-collected cervical vaginal specimens for DNA typing and comparing NHANES data from before the vaccine was available, 2003 to 2006, to after, during 2009 to 2012. Not only was there a decrease in the prevalence of the virus itself, but there were also dramatic declines in clinical disease caused by HPV. In Australia, where there was a high uptake, there was a decrease in both prevalence and incidence of genital warts among females, with a decrease of 50% in women under age 21 on an annual basis, and a decrease of 93% 4 years after implementation of the vaccination program. Overall, 3 doses of vaccine showed 76 to 93% efficacy against genital warts. Although there is no concern for cancer with genital warts, there is significant morbidity related to this infection because of the frequent recurrences, which can take many weeks to months to treat, and expense related to treatment. In addition, the treatment options can sometimes be uncomfortable, and the disease itself can be embarrassing and stressful. With respect to the potential oncogenic HPV strains, real-world experience has demonstrated declines in cervical cytologic and histologic abnormalities when looking at various age groups between 11 and 27 and comparing the vaccinated and unvaccinated groups. Studies are available from multiple countries, including first Australia, where women aged 12 to 26 within 5 years of the vaccination program showed an overall decline of 35% in low-grade and 47% in high-grade cytological abnormalities. Although the low-grade abnormalities commonly resolve on their own, especially in younger age groups, high-grade lesions are the ones most likely to progress on to cancer. In Canada, among 14 to 17-year-olds in 2 studies, there was a decline of 20 to 45% in low-grade cytologic abnormalities, indicating protection from active HPV infection. In Denmark, nationwide studies of 12 to 20-year-olds saw declines of 24 to 60% in atypia or worse cytologic changes, and declines of 13 to 33% per year. While in Sweden, when comparing fully vaccinated girls under the age of 17 to unvaccinated or partially vaccinated, there were impressive declines in high-grade abnormalities, with a decline of 75% for CIN2 or greater and 84% in CIN3, 2.6 to 5 years after introducing the vaccination program in that country. When looking at the U.S., where vaccine uptake has been lower than other countries, one study showed declines in the higher grade changes as well. When looking at girls and women with a mean age of 22 at vaccination and having at least 1 dose of HPV vaccine, there were declines when comparing vaccinated to unvaccinated women, with the largest decline seen more than 4 years after receiving the vaccine in CIN3 and AIS related to HPV 16 and 18, which declined by 45%, and CIN2 or greater by 72%. Not only were females who were vaccinated protected, but those girls and young women who did not receive the vaccine were also protected, indicating possible herd protection. Studies from Australia and the United States showed declines in the prevalence of HPV among unvaccinated females in the age group that were indicated for vaccination. This possible herd protection was also seen among unvaccinated males after females were vaccinated in Australia and Denmark, where decreases in genital warts were found in these unvaccinated males. HPV vaccine has the highest efficacy when it's given prior to exposure or infection with the HPV type present in the vaccine. It is important to emphasize that this is a prophylactic vaccine that will do nothing for HPV infection present at the time of vaccination. Studies have shown that prior infections with one HPV type does not impact the efficacy of the vaccine to the types to which the individual is naive with no prior infection. Unlike other vaccines such as MMR, there is no serologic correlate to immunity, and the minimum titer that is necessary for protection is unknown. The good news is that to date, there does not appear to be breakthrough infection when studying vaccinated cohorts over an extended period of time post-vaccination with the quadrivalent vaccine. As previously mentioned, there is no recommendation to use a 9-valent vaccine if the individual completed the bivalent or quadrivalent series. There also is no known duration of immunity for the 9-valent vaccine for either the 2 or 3-dose schedule. But based on studies with the quadrivalent vaccine, the duration is expected to be long-lasting. Use of hormonal contraception does not alter the immune response of the recommended vaccines on the adolescent platform, and they can all be given at the same time without any issues related to antibody response for either Menactra, Adacel, or HPV. Per the package insert, since this is not a live vaccine, there is no contraindication to vaccination when the patient is immunocompromised. There is concern about whether there will be a lower immune response, and 3-dose vaccine regimens are recommended. However, a recently published study from Australia addressed this issue in a multi-center clinical trial in 3 pediatric hospitals looking at children with solid organ transplant, stem cell transplant, JIA, and inflammatory bowel disease. The results were encouraging as there was an adequate immunologic response regardless of the age of the child or the cause of immunosuppression in the 24 months of follow-up. Now we're going to turn to vaccine safety. There have been nearly 90 million doses of HPV vaccine distributed in the U.S. since 2006. Based on monitoring, the HPV vaccines have proven to be very safe, with benefits greatly outweighing any potential risks. The most common side effects are mild and include pain, redness, and swelling at the injection site, similar to the side effects of any vaccine. The 9-valent vaccine was studied in more than 15,000 males and females, and the studies included more than 7,000 subjects who had received 1 or more doses of the quadrivalent vaccine. This is particularly relevant since we are still seeing youth who started the vaccination series with the quadrivalent vaccine but need to finish the series with the 9-valent, since this is the only vaccine currently on the market in the United States. Any pregnancies that occurred after day 1 of the first vaccine being given during the trials did not continue getting the vaccine series until the pregnancy was concluded. It was also rare for the vaccine to be discontinued because of any adverse events, and the frequency of adverse events were similar to those that were seen with the quadrivalent vaccine. In the clinical trials, 80% were female, 20% male. 1/3 were 9 to 15 in age, 2/3 18 to 26. 1/4 were from North America, a little over 1/3 from Europe, 1/4 from Latin America, and 13% from Asia. The racial distribution of the subjects was 59% white, 5% black, and 14% Asian. Most of the adverse events were not serious and were likely to be seen in females, but with a similar profile between races. Adverse events occurring with an incidence of 5% or more included injection site pain, swelling and erythema, and systemic symptoms of headache and fever, which was usually less than 102 degrees. Systemic adverse events tended to decrease with subsequent doses. There was more injection site adverse events for the 9-valent vaccine than the quadrivalent, especially if the subject had previous doses of the quadrivalent vaccine. Also, the injection site pain did increase with successful doses. However, most of these injection site symptoms were rated as mild to moderate and did not result in discontinuation of the vaccine series. Serious adverse events were reported in only 2.3% of subjects, with infections being the most common seen adverse event within 15 days among the subjects. Serious adverse events were defined as any adverse event that resulted in death or deemed to be life-threatening, result in a persistent or significant disability or incapacity, result in prolonged inpatient hospitalization, or was a congenital anomaly, cancer, or other important medical event. None of the deaths were vaccine-related, and the vaccine-related serious adverse events included pyrexia, allergy to vaccine, asthmatic crisis, and headache. Pregnancy outcomes were similar to the quadrivalent vaccine, and spontaneous abortions were within the range usually seen for pregnant women in that age group. Similarly, congenital anomaly rates were within the prevalence range in the literature and did not show a specific pattern to indicate causality from the vaccine. Syncope occurred in 0.2% of the subjects, with almost 1/2 occurring on the same day as vaccination. The overwhelming majority were in females, and they did not recur with a subsequent dose. Syncope is a known occurrence related to medical procedures, including vaccination, and is not unique to the HPV vaccine. This was not a cause of discontinuation in the study, but a reminder that patients should be observed for 15 minutes after vaccination. There is no evidence that the vaccine caused autoimmune disorders, complex regional pain syndrome, or postural orthostatic tachycardia syndrome. The contraindications to vaccination include a history of immediate hypersensitivity to components of the vaccine, including yeast, and it is also not recommended to be given when the patient is known to be pregnant. Having said that, however, a pregnancy test is not needed prior to administration, and no intervention is needed if it is given inadvertently during pregnancy. It is just recommended that one is to stop the series and resume after delivery, and any pregnancies can be reported to the registry. Finally, there are studies suggesting that the vaccine should provide long-lasting protection, since there was no evidence of waning immunity for the quadrivalent vaccine over 10 years of follow-up. There is no indication at the time that booster doses are needed. If you have any questions related to this webinar, please email Melanie Farkas at mfarkas@ohioaap.org. And now if you can please fill out the brief post-test below. Thank you very much.